Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Sonya Krishnan discusses how HIV-ASSIST can be used to guide ART selection for a person with HIV who is planning a pregnancy. Dr. Krishnan is an assistant professor in the Division of Infectious Diseases at Johns Hopkins University in Baltimore, Maryland. For the full online educational program, please visit the link in the show notes for this episode. Now, let's hear what Dr. Krishnan has to say.
So today we are going to talk about preconception antiretroviral therapy selection using HIV-ASSIST. And a person with HIV who reveals a plan for pregnancy, of course, needs careful consideration, as the stakes are high during pregnancy for people with HIV. They themselves have complications such as low birth weight, spontaneous early abortion, and infections such as sexually transmitted infections, bacterial pneumonia, and urinary tract infections. And these are more common in people with HIV while they are pregnant. But also, pregnant persons have historically been excluded from drug therapy clinical trials, leading to a paucity of data on the safety of antiretrovirals during pregnancy. So healthcare professionals must also consider the fetal toxicity of ARVs and physiologic changes during pregnancy that lead to altered drug metabolism when optimizing the treatment regimen for people with HIV who are pregnant. Physiologic changes during pregnancy may necessitate increased or more frequent ARV dosing during the second and/or third trimester. So let's explore this with a patient case. Let's consider a case of a 30-year-old person with HIV who has been virologically suppressed for the past several years while receiving bictegravir, tenofovir, alafenamide, and intracitabine with a CD4 T-cell count of 539 and no mutations or history of treatment failure. She is HLA-B5701 negative and acquired HIV through transmission by her partner, who has also been virologically suppressed for several years. She reveals during her appointment with you that she is seeking to become pregnant. So you want to make sure that her current regimen of Bic/Taf/FTC is a safe and efficacious option for her and any future fetus should she become pregnant. Now let's look how HIV-ASSIST could support treatment decisions in this case. So using the HIV-ASSIST online tool, I can create an individualized plan that suits the unique needs of my patient. I would enter into the tool that she is virologically suppressed with a CD4 count of greater than 200. She is HLA-B5701 negative, and her current regimen is Bic/Taf/FTC. Under the category of comorbidities, ARV side effects, or pregnancy, I would select pregnancy, preconception, or less than 8 weeks from last menstrual period. So from this, HIV-ASSIST generates a unique weighted score of all possible ARV combinations based on the specific treatment history and comorbidities of my patients, with a lower weighted score being more favorable based on the strength of evidence for maintaining viral suppression and minimizing adverse events, including risk to the fetus. Based on the top 3 outputs, ranked by the HIV-ASSIST weighted score, all recommended regimens actually contain dolutegravir as preferred integrase strand transfer inhibitors, or INSTIs, to anchor the regimen in combination with 2 nucleoside reverse transcriptase inhibitors, NRTIs. Of note, the tool has excluded Bic-containing regimens for this patient, and these weighted scores reflect HIV-ASSIST algorithms that are calibrated to the 2022 guidelines from both the U.S. Department of Health and Human Services and International Antiviral Society, USA. The HIV-ASSIST tool allows me to explore details about these recommended regimens. After entering my case, I can download an education sheet for patients who are pregnant or have childbearing potential that explains the rationale behind the weighted score. For example, despite older DHHS recommendations against the use of dolutegravir during pregnancy because of a signal for neural tube defects, DHHS guidelines have been updated to recommend either dolutegravir, abacavir, lamivudine, or dolutegravir and dual NRTI backbone as the preferred initial regimen in a pregnant patient. Similarly, on the education sheet, I can see why a Bic-containing regimen is not preferred in someone who is planning pregnancy. It explains how there are insufficient efficacy data during pregnancy. The tool also shows me why some regimens are ranked lower for this patient. For example, next to darunavir, ritonavir, and TAF-FTC, a red exclamation mark reveals additional dosing information and the tool's rationale that led to the final weighted score. It notes how darunavir, ritonavir must be dosed twice daily in pregnancy and explains how this increased pill burden led to a score adjustment, i.e. penalty, that makes this option less preferred than the dolutegravir-based regimen. The HIV-ASSIST algorithms attempt to balance consideration of efficacy and safety with those of tolerability and adherence. Increased dosing frequencies consequently are reflected as slightly higher, i.e. less preferred composite weighted score, although darunavir, ritonavir, and TAF-FTC is still identified as one of the favorable regimens. Lastly, I'd like to discuss how HIV-ASSIST is updated to reflect current guidelines. So this tool is frequently updated to incorporate new and updated guidelines, such as the recent IAS-USA 2022 and DHHS 2022 guidelines, which provide updated guidance on preconception planning and pregnancy in people with HIV. Based on the currently available evidence, dolutegravir is the preferred preconception INSTI, abacavir 3TC or TAF or TDF 3TC or FTC are the preferred NRTI backbones, and darunavir ritonavir is the preferred protease inhibitor, although it must be dosed twice daily to account for a decreased concentration, which occurs because of increased drug metabolism in pregnancy. Alternative regimens include those containing rilpivirine, raltegravir, or efavirenz. Of note, use of a regimen containing cobicistat as a booster is not recommended because of insufficient drug levels in the second and third trimesters. Doravirine and BIC have insufficient data to support use during the preconception period. All of this information is synthesized on the output page, with the DHHS preferred regimens weighted more favorably compared with the alternative regimens. So in terms of my ultimate regimen selection, I would use the output from HIV-ASSIST online tool to counsel my patient on a switch from BIC TAF FTC in her pregnancy planning phase. We would discuss a potential rare risk of neural tube defects in pregnancy while receiving dolutegravir, but also weigh that risk against the paucity of data on continued use of BIC during pregnancy and against the twice daily dosing required for darunavir ritonavir during pregnancy. Together, we would make a decision based on her needs and preferences, guided by evidence-based weighted rankings provided by the HIV-ASSIST online tool.
Thank you very much to Dr. Krishnan, and thank you to our listeners for joining in. To get more from our program, see the link in the show notes. You can view webcasts on the HIV-ASSIST tool, hear additional case examples, and see comments from other experts. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.